Chapter 15, the secondary assessment. 3 different types of patients we're going to run into. Medical patients, trauma patients, and patients we just don't know what's wrong with them. So they could be medical, they could be trauma, or they could be a combination of both. So we're going to use a couple different techniques to help us figure out which ones they are, identify those things that are going to kill them now if we don't fix it, and things that are nice to tell the hospital so they can plan ahead to figure out what they're going to need to do with this patient once we get there. So 3 parts of our secondary assessment: the physical assessment, the hands-on portion, the patient history taking, the history of present illness, and then some past medical history using the acronym SAMPLE to kind of put all the pieces together, and then our vital signs. Vital signs are going to be based on what you find in the first 2. Do you need to take more than just a blood pressure and a pulse and respirations? Do you need to add in eyes, skin temperature, actual temperature? It's going to be based all on what you're finding in the first 2 portions here. So a couple things we need to figure out. First is a sign. Sign is something to see, you can hear, you can smell, you can taste. Symptom is what the patient tells you. Vomiting is a sign. You can verify that. You can see it, you can smell it, hopefully you don't taste it. The symptom is nauseated. The patient says, I feel like I'm going to throw up. Until they actually spew chunks on your boots, it is still a symptom. Once they vomit, now it becomes a sign. So that's the quickest example I can think of on that one. And then the reassessment portion of your secondary assessment never stops. You're going to assess, form an opinion, and then go back and reassess and verify your opinion. And then you're going to reassess to make sure nothing changed to change your opinion. So reassessment is continually going on from the start to the finish. For medical patients, if they're responsive, we can focus in on what they tell us is wrong. So if they say, I'm having chest pain or I'm having lower abdominal pain, we can focus our physical assessment based on what they're telling us. So they're answering our questions, they're getting our OPQRST and sample questions answered for us, and we can use that to kind of focus in. We do need to be knowledgeable enough to know that if it's chest pain or difficulty breathing, we're going to assess things away from the chest that give us clue on how well or how progressed the problems are within the chest. If they're unresponsive or unable to answer our questions, a medical patient gets treated the same as a trauma patient. We're going to have to do a lot more hands-on assessing to try to figure out what's wrong with them and determine what we need to fix. So for the responsive medical patient, we get a good history using sample OPQRST, and then based on what they tell us, we do our physical exam. We get our baseline vitals, and we treat our patient. If we find something wrong that needs immediate treatment, we treat it. If it's something that we can treat on the way to the hospital, we wait until we're in the ambulance, and then we transport them to the hospital and get them the care they need to continue the treatment process. So when you're doing the history, you're talking to the patient, asking them the questions: what happened today? What kind of symptoms are you having? What were you doing when they started? With your OPQRST. Then we go, we get our sample as our foundation for our questions. Do not just tell I need to get the sample history and expect them to know what that means. Use your family, bystanders, anybody that can confirm what the patient tells us. Even if they are talking to us fine, you're still going to ask questions for the other people around the scene. Ask open-ended questions where you need to, closed-ended where you need to, and biggest thing is get down on their level and use their name and get them comfortable with you. As you're asking questions, listen to what they tell you and move your questions in the direction that they're leading you. Patient says they're having chest pain. When did it start? About 2 days ago. Okay, do you have any history of this before? What happened last time? Do you have any family history, since we know that a lot of cardiac disease is hereditary? Do you have diabetes, high blood pressure, high triglycerides? Things we know are contributory factors. Do you smoke? Do you drink alcohol? Ask questions that go with what they're telling you. But these are going to be things you pick up over gaining experience and learning more information. So don't feel like you have to have them all up front, but you're going to pick them up as you go. Because you've got to focus based on what they tell you, you can do a brief physical exam. Just check what you think you need to. If the patient can verify it's their ankle that hurts, all you have to do is examine both ankles. Both because you want to see symmetry, but that's all. You don't have to examine everything. So focus in on what you find, or what they tell you to find. Baseline vitals, you want to have at least the baseline in 2 sets to give you a good idea. We always like to get a good manual just to verify what's the automatic given is on the blood pressures. And then we're going to look at trends. Are they going up or down? And knowing what those trends mean to us. If something in the chief complaint, mechanism of injury, the history taking says, oh yeah, this is a critical patient, let's do our further assessment in the back of the ambulance on the way to the hospital. A friend of mine told me when she had a cardiac arrest, survived, and she had chest pain one time, and the paramedics didn't think she was serious. If a person has been dead before and they survived, treat them as critical just in case they don't die on you again. Kids, get on their level, ask simple questions, use the paramedics, use the parents, big caregivers, bystanders, anybody that can help you get the kid comfortable. Unresponsive patients, medical, trauma, ask questions of the bystanders, get your vital signs and a basic assessment, and a rapid entire body assessment. And so we're going to do head to toe, and we're going to talk about what we're going to include in those. The rapid trauma assessment for a medical patient is identical to what we do for a trauma patient. Because we don't know what's wrong, because they can't tell us, we're going to want to check every body part to make sure that we don't have any life-threatening things that we can fix somewhere on their body. So it's head, neck, chest, abdomen, pelvis, extremities, and posterior. The neck, we're looking for jugular vein distension. Are the jugular veins popped out? Look for medical devices or medical identification devices. Do they have a necklace on that says what's wrong with them? Chest, we're looking for breath sounds. We're looking for integrity of the chest. Belly, we're looking for distension, rigidity, or firmness. Pelvis, because it's not trauma, we're not concerned about the structure of the pelvis, but we're looking for incontinence. Can they maintain their bladder and bowel? If they don't, that's a sign there's a problem. Extremities, we're looking for circulation, motor function, sensation, oxygen saturation. Put a pulse ox on them. Look for medical devices or medical identification devices. Do they have a bracelet on that tells you what might be wrong? Check the pupils. Are they round, reactive to light? Get the baseline vitals. Pulse, respiration, skin, pupils, blood pressure, skin temperature. Look for any abnormalities. O2 saturation, capnography, EKG. It all kind of depends on what you find wrong with your patient. Do you need to call ALS? If the patient is unresponsive, altered mental status, consider ALS a good option. If you're going to take time, if it's going to take longer to get ALS to the scene than you to drive to a hospital with doctors, choose to go to the hospital. If you can meet the ALS on the way, that's another option too. Most services in larger cities, you work with paramedics. You don't have to call ALS. But for our training purposes, we're going to assume you're a BLS ambulance, and you're going to need to make a determination, is this patient sick enough to need ALS? Start asking history of the patient, bystanders. What's the patient's name? What if the patient tells you a different name? Now you've got to sort it out. Do the bystanders know the patient's real name, or does the patient? Had a guy that he told me his name was Ralph. His date said his name was John. Turned out his name really was Ralph. He had used a fake name for his date. So pay attention to what they say and try to sort these things out. History of present illness, what happened, did you see anything, did they say anything before this happened, do you know if they have any other medical condition, do you know if they have any medications with them, or do they take anything? So look for any history that might tell you they might have a spine injury. Now we're going to go over the Nexus protocol, which helps us rule out spinal injury and determine what we need to do. But if you think they need it, put them on the long back board, or at least protect their neck. And we're going to talk about those options as we get there. But for our assessment purposes, until we know for sure, until we can go through the whole protocol, have somebody stabilize their neck until we can rule it out. The next thing we're going to look at is our secondary assessment of the trauma patient. How to get more information based on a hands-on physical assessment of your patient to determine what's our next step here. We're looking for anything that could be wrong with them. If it's something we need to treat, we're going to treat it right then. If it's something we can treat on the way to the hospital, we'll do that. If it's something we just need to identify, we just identify it and put it in our documentation. So we're going to have some decisions to make as we go through the process here. Look for the location of the injury. A laceration of the finger isn't nearly as bad as a laceration on the neck. Check the patient's mental status. Anything that is not oriented, alert and oriented, is not normal. So that tells us there's something going wrong with our patient. So we're looking for the airway status, that's our ABCs, vital signs, mechanism of injury, their age or pre-existing conditions. What we mean by that is younger or older patients have a higher likelihood of getting serious results from minor injuries. And then other people with pre-existing conditions, like if they've got a lung disease and they get an injury to their chest, it makes it even worse. If they are conscious and alert and can tell you exactly where it hurts and what happened to them, you can focus in on what they tell you. I was running up the incline and I twisted my ankle. You can check my ankle. That's all you need to worry about. Focus in on my chief complaint. Maybe ask me a good history. Does anything else hurt? But if I say no, I just twisted my ankle, then you can focus there. Get a chief complaint. What is wrong with you? Why did you call 911? What happened? History of present illness, nature of illness. How much force was involved? Did they fall down 2 flights of stairs, or they trip over a brick in the sidewalk? What direction of the force and how hard was it? Did they have protective equipment on? Were they wearing their bicycle helmet when they crashed? What happened before we got here? Did somebody try to splint it? Did they put ice on it? And then what hurts? Tell me where it hurts so I can focus my assessment. For physical assessments, we're focusing on the injury and chief complaint. Mechanisms tell us what might be hurt, like we talked about with the injury patterns from the different vehicle accidents. If they get hit in the driver's side, you expect to have injuries to the left side of the body. So use that to help us guide where we're going to look for our injuries. 3 things we're going to do for our assessment. Look, listen, and feel. Observation, looking, palpation, feeling, and auscultation, hearing. So we're going to look, listen, and feel for our patients. We're looking for abnormalities in our patients. Symmetry. The body should be the same right and left. If it's not, your first question is this abnormal? If they can tell you, or somebody else can tell you, yes, he's got one leg shorter than the other normally, then we're good. If you don't know, assume it's a new abnormality. Look for the color. Ask what the normal color of their skin is and what the new color is, and compare. Look for shape. Are there any deformities? Look for the ability to move it. If you've ever broken a bone, you know it's really hard to move it. Palpation. Does it feel different? Does it feel bigger? Does it have a bump in it that should be there? Is the skin cool, warm, moist, dry, hot? What's it telling you? The sensation, do they feel you pushing on it? Auscultation, you're going to listen to the breath sounds with your stethoscope. Can you hear air moving in and out? If you can, what's it sound like? Do you hear any bubbles? Do you hear any wheezes? Do you hear things that shouldn't be there? Here's another acronym for you. DCAP BTLS. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, swelling. This is our acronym that we're going to use to remind us what we need to check as we go through the body parts. Each body part, you want to look for DCAP BTLS. If you find it, note it. If it's something that's going to hurt them, you fix it. Good set of vital signs. You can do this right after you do your ABCs. You've determined your patient needs to go to the hospital right now to get a set of vital signs. Have the another EMS provider get the vitals while you start the baseline, the assessments. If you think there's any spinal injuries, hold the head in place, put a C-collar on them if you can, but the biggest thing is hold them still until you get to that point. We're going to talk about putting C-collars on, different types, different ways to put them on. Biggest thing is to make sure you got the right size so you don't push the jaw back or up too high. So you have somebody holding the head in place. You put the collar on. This one's adjustable. You could choose the size. A lot of it's eyeballing, or you put it on low and then move it up higher so you get the head in a neutral position, and then you lock it in place. And we will practice those in class. Remove any jewelry, move the hair. You don't have to remove the hair, just move it out of the way. Hoodies make it even more difficult, so you try to get rid of the jacket or a hood or anything with a high collar. The goal is to keep the head neutral alignment. If it doesn't go back to neutral because of some type of injury, don't force it. That would be bad, but just kind of maintain the position where you are. Multisystem trauma, serious injuries, consider spinal right away. Just because they're unresponsive and can't tell you what might be wrong, you're going to consider spinal and protect them. Call ALS. They can help ensure a good airway, and they can treat a few of the life-threatening problems you might find. And then you do a rapid trauma assessment. This is a head-to-toe assessment that takes 30 seconds to a minute and gives us all kinds of good information on what we need to treat right now. So the rapid trauma assessment, you're starting off from the head, working your way down to the body, down through the core of the body, and then to the extremities. And then once you do the extremities, you roll them to put them on the back, or on the backboard, and you can check the back. So you see here they're doing a head assessment, hands-on. You're looking at what's going on, you're feeling, and you're trying to see if you have any blood show up on your gloves or anything that shouldn't be there. Some things you're going to worry about that you won't be able to find by just looking. Seatbelt injuries. They can cause rapid deceleration in the body. Airbag injuries or steering wheel injuries all push on the chest and sometimes don't leave any exterior damage for us. So stabilize the head. Put the C-collar in as soon as you're done assessing the neck. And then as you get them ready to transport, you're going to put them on a backboard and secure them to the backboard following local protocols. Call ALS. Usually this is done in your primary assessment when you get there and say, oh wow, I'm shocked they're still alive. Call ALS. If you find something that you have to fix in ABCs, call ALS. So know what the resources are in your area, know where the closest ALS units come from, and how close you are to the hospitals. That helps you kind of figure out where you take the patient. Rapid trauma assessment, just a couple minutes at the most. That's done on scene. So it's before you get them out of the car, it's before you load them up in the ambulance. It's a quick, hands-on, quick assessment for your patient. Once you get them in the ambulance on the way to the hospital, then you continue to reassess. You may do a couple more rapid assessments, but your initial one's done on scene. So starting at the head, you're going to palpate the cranium, the face, nose, eyes, mouth. Look for blood or clear fluids. Clear fluids would be the cerebral spinal fluid that could be leaking out because of a fracture. Battle signs, that is not an immediate sign. It takes about 24 hours to develop. So if the patient has battle signs, bruising behind the ears, that's a long-term result of a head injury, a fractured skull, and that tells us there's a history of trauma that happened long before we got there. A friend of mine had a fractured skull, and her battle signs were developing about 24 hours out from when she had the head injury. Assessing the neck, you're looking for decap BTLS, wounds, tenderness, jugular veins distension. You're looking for a tracheostomy or stoma. You're looking at the trachea to make sure it's in the center of the neck. You're looking for any open neck wounds. Those are ones we're going to have to treat right away. Once you do that, you do the C-collar. Put the collar on so that they don't move their head, but you're still going to have somebody holding them. The chest assessment. First, you're going to check the collarbones, the clavicles. Push on them to make sure you've got a good foundation. Then you're going to take the chest, expose it, and look for paradoxical motion. Do you see any holes that you missed during the primary assessment? You're going to listen for breath sounds. Do you hear air going in and out both sides equally? And then you're going to palpate the chest. You palpate down the center of the chest, down the sternum, and then you grab the sides of the chest and squeeze in. That gives you good assessment. If you find any crepitation, any bone grating against bone, then you do a more thorough inspection of the chest, touching more thoroughly to make sure to try to find out where that crepitation is coming from. Show and kind of get an expand. Ask them to take a breath while you get your hands like this. Then you can see how your thumbs go apart, and that tells you how well they're breathing. Listen. Do you hear air going in and out? You want 2 up at the top of the lungs, just above the nipple line, 2 on the mid-axillary line on the sides, about midway down from the chest, and then 2 in the back when you get to that. So you're looking, is it there or not? Is it equal on both sides, and do you hear anything abnormal? Belly, you look at it first. Do you see anything distended or protruding? If you have guts coming out of a laceration on the belly, this is not a time where you press on the belly gently. If you press and more pops out, that's bad. So we're going to skip that one. But if they're not, then you push gently and firmly into each of the 4 quadrants to see if you have pain. If the patient has pain, you feel anything that's abnormal, like you feel a heartbeat in a large mass, that's a problem. That's a rapid transport situation for you. Looking at the pelvis, do they have a history of any problems? Did they have a mechanism that could be a fractured pelvis? You're going to push down and in, and then you're going to look at the genitalia if necessary. If the patient is a male and has an erection, that means they probably have a spinal injury. Unresponsive patients with an unknown source of an erection, there's some type of spinal cord injury that we need to be aware of. If there's any genital injury, then we treat it. Push on the belly. We're looking for, is it soft, firm, distended? Rapid assessment of the extremities. We're doing decap BTLS from the top of the leg down to the foot. We do one leg, then we do the other leg. Once we get to the bottom, we check circulation, sensation, motor function, CSM. If they're unresponsive, we will not get sensation or motor function, but we at least get pulse or circulation. And then we do the upper extremity. We check for the same thing, decap BTLS. We check for a pulse. Can you wiggle your fingers? Can you feel the finger? Can you move your hand up and down? Can you move your foot up and down? Based on experience, I would recommend you give them one finger to squeeze. If they get mad or they've got a really strong grip and you give them two fingers, there's a good chance they're going to break them. One finger, they can't really squeeze it against anything other than you can feel the pressure. So one finger only for squeezing. Checking the pulse behind the tibia, posterior tibia, that's the medial, then you can check the lateral, or you can check the dorsalis pedis, the pulse on the top of the foot. If you find it, mark it. You know it's there, you can go back and find it again. Once you get all four extremities done, everything on the front, now we're going to roll them gently so that we can put them on the backboard, and as you roll them up, you're going to check the back. We want to do it all at once so we don't move them around more than necessary. Get another set of vitals, get the pulse ox, get some past history now, start putting pieces together. Here's rolling and checking the back. You want to check the spine down the center. You want to check both sides of the back and the flanks. You want to check the buttocks and the back of the legs. So we're going to be rolling our hands down the whole body here to see what's wrong. Tell the patient what you're doing. If they're conscious or unconscious, you're going to talk to them. Expose the area before you examine it. We need to be able to see what we're touching and touch what we see. It helps us to know where there might be problems before we actually do it. Keep an eye on your patient's face as you're palpating. They may not say they're in pain, but the face it's hard to hide the pain. So you look at their eyes, you can tell what's going on. Spinal protocols if necessary. If you find something that you missed in the primary assessment that you need to fix right now, stop and fix it. You don't have to say, I have to finish this assessment before I go on. You can stop and fix life threats immediately. Some pediatric notes on the head. Do not push on the fontanelles. They are good tools for us to use to see if there's increased pressure. But if there are, don't push on them. Because kids are so top heavy, they have head injuries real easy. Look for mucus or anything in the nose. One, it's going to cause difficulty breathing. The other is it's a sign of a head injury. So it gives us a couple things there. Kids have very little necks, very short necks, kind of stubby looking things, and they have very poor neck muscles. So their head pops around way too much, and they can cause spinal cord injuries without any fracture. They can actually bend it in half and not cause any damage to the spinal column, but can have airway or spinal injuries. Keep the head in the neutral position. They make special backboards for kids that have a little cutout behind the head, or you can just roll a towel up and put it behind their shoulders. Chest, sometimes they can have injuries to the interior without any exterior signs because the chest wall is so flexible. Any little damage to the belly can cause difficulty breathing. Any distension or tenderness, kids are really big belly breathers, so if they have that compromise to the abdominal cavity, they're going to have difficulty breathing on top of everything else. Pelvis, look for stability there. If a kid has a fractured pelvis and there's no mechanism, something's fishy here, and make sure your law enforcement knows that there's a potential that something's not adding up. Cap refill on the kiddos works great, and then decap BTLS on them. Once we get the rapid assessment done, we've confirmed that ABCs told us that the patient was critical. We got him in the back of the ambulance. Now we go back and do a detailed assessment. This is a review of everything we've done the first time for the rapid assessment, but we're just taking a little bit extra time, going into a little bit more detail, and most of the additional detail is coming from the neck up. So we're looking at the eyes better, we're looking in the ears, we're looking in the nose, looking in the mouth. We're trying to gather all this additional information to let the hospital know what might be wrong with them so they can kind of guide their treatment once they get there. Sometimes we may never even get past the rapid assessment. You do a primary assessment, you find what's wrong, you're trying to fix them. You do part of a rapid assessment, and that's as far as you get because you keep finding things that are life-threatening, and you do what you have to do to keep your patient alive. Anytime the patient changes, we go back and redo our whole assessment process. We go back and redo it every 5 to 10 minutes, depending on how stable your patient is. Just making sure your patient's not changing on you without your notice. A detailed assessment, remember, it's going to take more time, so you don't do that until all your critical interventions are done. Until your bleeding stopped, your airway secured, all the critical broken bones are splinted, then you can go back and do a detailed assessment. For detailed, it's just like the rapid. You expose them, looking for things that could be wrong. You're working around immobilization equipment. You don't take anything off. This is also a good time to check your immobilization equipment to make sure it's not causing problems. As injuries progress, they tend to swell, and that might put more pressure on things, and you might lose your distal pulses. So that's a good thing we do this rapid physical assessment and try to figure out what might else be wrong with them. Patients not seriously injured, you just focus in on what they tell you. Maybe asking history, they fell down a flight of stairs and the only thing that hurts is ankles. I'm probably going to check the head, neck, back, just because they fell down a flight of stairs. The other thing you got to worry about is the emotional support of your patient. If they're conscious and alert, they're probably scared. So now you've got another side to take care of. You need to reassure them and talk to them and tell them that everything's okay. You're there to help them, and we're going to find out what's wrong with them and get them to the hospital where they're going to take care of them even more. So as always, if you have questions, write them down, bring them to class, and we'll have some good discussions. Thanks, and have a good night.